A new study has found that many of South Africa's 8.2 million HIV-infected people are immuno-compromised and can harbor the coronavirus for much longer. Research that was carried out on an HIV-positive 36-year-old woman showed that COVID-19 stayed in her body for 216 days and mutated rapidly. Joining us for more insight into the study's findings is Professor Sinead Delany-Moretlwe from Wits University. Professor Delany-Moretlwe, thank you for your time this afternoon. Perhaps before we start, getting alarmed by numbers such as the virus staying in your body for 216 days, what is the average number of days that the coronavirus actually stays in the human body in somebody who perhaps does not have HIV/AIDS?
Mm-hmm. Well, thanks very much for having me on the show. What we know about SARS-CoV-2, the virus that causes COVID-19, is that most of us will clear that infection with our immune systems, and that's why only a small fraction of people actually go on to have more severe disease and to need hospital admission. There are people whose immune systems haven't been able to manage the virus, and in some instances their immune system overreacts to the virus, and that's what causes them to end up with severe disease. So the issue with people living with HIV, as we know, the underlying problem with HIV is that it compromises the immune system. It doesn't work as well. We've been fortunate to discover antiretrovirals, and so if people are tested, know their status, and are on antiretrovirals and have their viral replication under control, they can live virtually normal lives. But in this situation, under normal circumstances, most of us with SARS-CoV-2 infection could probably clear it within 30 days. That's kind of what we've seen from the studies, is that the virus is gone sort of within usually 2 weeks, but sort of out to 30 days maybe. But the challenge in people who are immunocompromised is that their immune system obviously is not strong enough to clear the virus, and so it stays in their bodies. And the challenge for us there is that as the virus kind of persists, it can mutate. Viruses are always kind of replicating themselves and using the body's machinery to replicate themselves. And with time, those replications can emerge as variants. These variants can actually sort of be more sophisticated at hiding from the immune system. And this is really sort of the underlying cause for concern, is that, kind of if there are enough people who aren't on antiretroviral therapy and they're exposed to COVID because they're not vaccinated, that maybe we may see the emergence of more of these variants, which have been a challenge, like the Delta variant.
So let's look at the mutation process then for a while. Does the mutation process happen within the human body? And does it mean that the longer the SARS-CoV-2 virus stays within the body, the higher the chances of it mutating a number of times?
Well, I think the fundamental concern that we have is not sort of so much the time, but the fact that the immune system has not been able to clear the infection, and that clearly there are in this battle that we have between us and the virus might be escaping our efforts to control the virus, and that's what's worrying us, because if more and more of those viruses that are able to escape the immune system accumulate, those are the ones that we know sort of become variants. And if those variants get transmitted, we end up in a situation where we have more and more variants out there that we're not able to control with our current vaccination strategies. So I think the important thing for us to focus on is that we can address this, and one of the biggest things we can do is encourage people to vaccinate. I was just looking at the data from today. It looks like we have 28% of the population fully vaccinated. We're trying to get levels now, kind of in excess of 80%. So we have a ways to go. And the important thing, I think, for anyone living with HIV to know is that, it's important that they go out and get vaccinated. One of the best things that they can do is go out and get vaccinated. The other important thing that we can do is actually strengthen our HIV treatment programs and our testing programs. And we know that during COVID, one of the biggest impacts has actually been to disrupt those programs, and so much of our health resources have been shifted to COVID. But if people test, if they're on treatment, and if we also strengthen our prevention services so that people are not getting infected with HIV, and we add vaccinations on top, we may be able to kind of mitigate some of these concerns that are arising about the emergence of variants in people who may not be fully controlled on, they may be undiagnosed, or they may not be fully controlled on their antiretrovirals.
Do you have the numbers of how many HIV positive people have actually been vaccinated so far?
So at the moment, the kind of publicly available data is not being has not been presented, but kind of if we can assume that sort of 28% of the population has been vaccinated, we can assume that a fraction of them are going to be people living with HIV. But I think we clearly need to do more to kind of accelerate our vaccination program to kind of reach the coverage targets that we want. And some of what we hear is that people are concerned about the safety. So I think we need to do more to message that even if you're living with HIV, it's important to be vaccinated, and that vaccination can help, as well as kind of ensuring that you're on your medications. And for people who don't know their status, that in fact they do know their status.
Do you believe, Professor, that there perhaps should have been a differentiated, more targeted approach to the vaccination of those who are HIV positive, specifically considering the fact that there are more than 8 million HIV positive people in South Africa? And as you mentioned, vaccine hesitancy and not being quite sure of whether you yourself are eligible for a vaccine if you are HIV positive.
Yeah, it's an interesting question, because the goal of a vaccination program, or the current vaccination program, is primarily to prevent severe disease and death. And so that means making sure that vaccinations are targeted at people who are elderly or have comorbidities. From the data that we've seen so far, people who live with diabetes or have hypertension or comorbidities like that clearly have increased risks for severe disease. Some of the data that we've seen on HIV suggests that they may have a slightly increased risk, not perhaps so much as people who have some of these cardiovascular comorbidities. But what we have observed is that the people living with HIV who are at highest risk for severe disease are people who are not well controlled. So people who are either undiagnosed and not on antiretrovirals, or who are on antiretrovirals but taking them periodically. So this tells us that the immune system is really important in your response to COVID. And if you're HIV positive, one of the most important things to do is to be on treatment. But on top of that, I think we also are learning that vaccines are safe and can be used in these populations. The remaining question, and one of the questions that's being addressed in a trial currently being run in South Africa, is whether we need to potentially think about boosters in some of these vulnerable populations, including whether we need additional booster doses for people living with HIV. But there we don't yet have evidence either way, and so it will be important to do that research to answer those questions.
Talk to us about the magnitude of the study. I mean, what I have in front of me is a study of an HIV positive 36-year-old woman. Now, we have seen with the vaccinations, people react differently to them, just depending on what comorbidity you might have or what underlying symptoms you might have before even taking the vaccination. How vast is the study, and what are the different ways that people who do have the HIV virus in their body, how have they reacted?
Yeah, so I think a couple of things. The first is that this study that you're talking about was really helpful for sort of confirming a hypothesis that many people had, that perhaps variants were emerging in people who were immunocompromised. And in our region, sub-Saharan Africa, we have lots of people with undiagnosed HIV, and therefore that's a potential sort of source of vulnerability. So it really confirms a hypothesis. A second set of studies have really looked at the safety of these vaccines in people living with HIV. So large numbers of people have been enrolled in these COVID vaccine studies. And in South Africa, we have recruited populations of people living with HIV into the safety studies, and we haven't seen big differences in terms of the safety profile. So it's not as if there are different reactions if you are HIV positive. And generally, kind of what we know is that these vaccines are safe and well tolerated. Most of the experiences post-vaccination are mild and self-limiting, and rare events occur really rarely, kind of as in, kind of a handful of people amongst millions of doses administered. So I think the key message is that these vaccines are safe irrespective of your HIV status. I think it's important, kind of if you have concerns, to speak to your healthcare provider who knows the details of your case, who knows the medications that you're on, kind of because it's really important that people's individual concerns are addressed. But kind of the data so far, is encouraging about vaccination of people who are living with HIV.
And what is the penetration within the rural areas as far as education for those who may be HIV positive but still need very specific information regarding how the vaccine will react to their bodies as well as whatever medication that they may be on?
Well, I think what's been impressive, in fact, is that it's provinces that have rural populations that actually have some of the highest coverage rates in our vaccine program. So clearly they're doing something right, and we should be finding out kind of what that is. And my sense of what they're doing is that there is a lot more recognition that when people can't come to you, you go to them. And I think sort of the other important thing is, kind of that we are integrating our services. So we have a very big antiretroviral treatment program. What we need is people in those programs who are already attending healthcare services to also have access to vaccinations and information about vaccinations. And I know that there is work amongst the treatment program to really consider how we get behind the vaccination program and how we integrate these messages so that people are reassured that, kind of by both fighting HIV and kind of fighting COVID with vaccination, we can mitigate against the sort of potential emergence of variants.
Professor, thank you very much for your time and your insight this afternoon. That's Professor Sinead Delany-Moretlwe from Wits University. Now, in just a moment, we'll